Continuing on with our head injury and treatment, we're looking at conservative treatment unless there is an increase in ICP. So we have to look for factors that would cause an increased intracranial pressure. Also looking at compound fracture of the skull. We want to make sure that their airway is assessed every single time you assess them, which should be frequently, making sure the respirations are counted for a full minute. Head of the bed should be 20 to 30 degrees. Body alignment is crucial because bodies that are out of alignment will increase the intracranial pressure. So you want to not disturb them too much and keep them calm and make sure that they're aligned. Principles for caring for patients with a head injury. So you want to make sure they don't get a secondary injury. So treat cerebral edema and manage the ICP. The diagnosis should be made and they may have to go to surgery. Skull fractures. Again, if they have an open skull fracture, they are at risk for infection. For depressed fractures and fractures with loose fragments, a lot of times they will do a craniotomy to elevate the depressed bone and remove any free fragments that are in there. And if there's a lot of bone fragments that are destroyed, the bone might entirely be removed. Sometimes they'll do cranioplasty at a later date. So craniotomy is generally performed to visualize and allow control of the bleeding vessels. They might do a burr hole, B-U-R-R hole, and that is just to release some of the pressure. It's done really in emergencies. And sometimes they will put a drain. The patient will have to go to a special neurologic unit where nurses are trained to monitor the drain. Review of subjective and objective data. So respiratory, you're going to look for the objective, rhinorrhea, impaired gag reflex, inability to maintain a patent airway. So in other words, they can't protect their own airway due to unconsciousness and or problem in the brainstem, so they would have to be intubated. We're looking at impending herniation, so that would be something again with the brainstem that you're going to monitor and watch for worsening level of consciousness. For cardiovascular, you're going to watch for impending herniation. This is called Cushing's triad, and it is related to the doctor who came up with Cushing's disease diagnosis, same physician. Cushing's triad would be a elevated systolic blood pressure, a widening pulse pressure, so the pulse pressure is the systolic minus the diastolic, and then bradycardia with a full bounding pulse. So elevated systolic blood pressure, it keeps going up. The diastolic stays the same, so the pulse pressure widens, and then they're bradycardic. That's a late sign. GI, they can have vomiting, projectile vomiting, bowel incontinence, and then of course bladder incontinence. There's a list of objective data, and of course there's more. You really have to assess every portion of this patient's body. This is posturing, decorticate. You notice at the top, their hands are up and to the core. They're centralized. Decerebrate, where everything's extended down. Of the two, if somebody said to me, you can be decorticate or decerebrate, I'd rather come in decorticate. That has a better outcome, but neither one really has a great outcome. These are clinical signs of diffuse axonal injury. And again, these people are going to be unconscious. Decorticate posture is abnormal, and again, bent stiff arms to the core, they're clenched. It's a sign of damage to the nerve pathway between the brain and the spinal cord, but again, not as bad as decerebrate. Decerebrate is extension. The muscles are tightened and held rigidly, and it usually means really severe brain damage. The acute intervention, you want to maintain cerebral perfusion. So in any way, shape, or form, make sure that they have a heart rate that is compatible with life. Make sure they're breathing. At the injury scene, you want to make sure that you have their head and their neck secured, so the C-spine. And the general goal of nursing management is to maintain cerebral oxygenation. So really watching vital signs, watching respirations, things like that, especially in the unconscious patient where you can't tell what's going on. You do use the Glasgow Coma Scale, and this is used constantly. Glasgow Coma Scale is great because it's the same here as it is in Philadelphia and Boston and New York. In Seattle, it's the same scale. So sometimes you may see some subtle differences in what people would say is a 9 or a 7 or whatever. When you are approaching the patient, this patient doesn't need much to have their ICP elevated. So approach carefully, make sure you speak first. Don't touch a person who appears to be sleeping. It may startle them. So really stay calm. Have the family stay calm. And as I've said all semester, if the family is crying or talking too wildly around the client, then send them off to see the new vending machines. You really want to stay calm, and there's things that patients' family members can do. They can take some cream and rub it into their hands or their shoulders, and just real gentle, everything real gentle. So for head injuries, I can't stress enough the use of helmets has led to fewer TBIs. Children should be wearing helmets when they're on tricycles, bicycles, anything like that. You still see motorcyclists riding around without their helmets. I'm not going to go on that, but they really need to consider what's going to happen in the end, not only to themselves, but to the loved ones and everybody else. If they are on a motorcycle or even on a bike, they shouldn't be under the influence of anything. Seat belts, we find that seat belts are better and better, and airbags too. We hear about bad things with airbags, but they save more than they injure. Protective helmets are used by lumberjacks, construction workers, miners, horseback riders, bike riders, snowboarders, skydivers, so just be careful. Main focus for nursing care for the brain injured person is centered around intracranial pressure. So they also have to look at other things too. They have to look at the eyes. The eyes become dry, especially if they're on a ventilator, so they're at risk for corneal abrasion. So you want to make sure that they have some lubricating eye drops. A lot of times we tape the eyes shut to prevent the abrasion. Periorbital ecchymosis and edema decrease with time, but cold and warm compresses will give some comfort. And diplopia, you can relieve that with an eye patch. The goal too, you can see on this, hyperthermia, you really don't want them shivering. You want their goal temperature to be about 36, 37 degrees. Don't let them shiver. That increases the intracranial pressure. Here's some other things, just reminders. It's the same thing over and over. Elevate the head of the bed. Loose collection pad under the nose, so if they're draining any fluid, it is more likely than not cerebral spinal fluid. So you want to watch that carefully. Don't place a dressing in the nasal cavity or the ear cavity. Also make sure patients do not sneeze or blow their nose or anything like that. Nasogastric tubes shouldn't be used. Watch nasotracheal suctioning too. That should not be done. It's going to increase intracranial pressure. Antiemetics should be given for vomiting because, again, that will increase intracranial pressure. And Watch for bowel and bladder function, skin care, infection, anything like that. You're going to treat them carefully because they are at risk for all kinds of extra problems. Acetaminophen will control headaches, so get an order for that. And patient is often unconscious before going to surgery, so make sure that a family member, a competent family member, is going to sign consent. There's a lot of times some ethical issues here. This is when an ethical consult can be called, and you can always recommend it. That's within your scope. You can't carry it out, but you can always recommend it. Increased intracranial pressure, we are going to be talking about that more and more. It is associated with very high mortality, and if the person doesn't die, they have poor functional outcomes. So really doing everything you can to make sure that they keep their intracranial pressure as normal as possible. A lot of times, once the patient is awake, we start replacing nutrients about 3 days after the injury, and then you want to get to full replacement within 7 days. Now, again, a dietitian may be consulted, and of course physicians, but you want to recommend in case anybody's overlooking. When you're evaluating for intracranial pressure, look at the signs and symptoms. The first one, and have we heard this all semester or what? Altered level of consciousness. This is usually an early sign, so they don't seem to stay awake. I'm not talking in the middle of the night. I'm talking during the day, or they just woke up and now they're going back to sleep. Look for confusion, restlessness, irritability. When a patient is pulling things apart nonstop and they were the ideal patient before, something is up. Look at the pupils. Sometimes this is harder to see. This example everyone could see, but maybe it's going to be smaller than that. And then look to and see, is their reaction sluggish? Ask about neck pain. Are they able to move their neck? Does it hurt? Ask about headache. Ask about nausea. And of course, vomiting, you can see. Late signs will be vital signs changes, so Cushing's triad. If they're fixed and dilated, you missed it. The key to this type of nursing is frequent neuro assessments and frequent Glasgow Coma Scale. By the time you're finished with one patient, you'll have memorized the whole Glasgow Coma Scale. You want to make sure that they're breathing. You want to have airway equipment in the room, something to keep the airway open. You want to know where the crash cart is. You want to get everything ready just in case. Head of the bed elevate 30 degrees. And patients with increased intracranial pressure are at risk for low cerebral perfusion pressure. Don't worry about looking at that or trying to figure it out. I don't see that that's really necessary for us to calculate. You want to protect them from injury. They are always at risk for seizures, so make sure they have padded bed rails. Acetaminophen should be ordered in case they do become febrile, and increased temperature contributes to cerebral metabolism. So for every 1 degree Celsius, the brain metabolism increases by 10%. So that's not good. That will cause problems too. So you want to know increased temperature contributes to the cerebral metabolism and makes the brain work harder. We want to rest and not increase intracranial pressure. Now, bringing in from the last group that we were looking at, and that is endocrine, you're going to monitor for SIADH or DI. So watch the urine output. If it's slowed down, SIADH. If it's coming out too much, DI. But anyone with a head injury at risk for one of these two things. Now we're going to look at stroke. So the case study for stroke had you looking at ischemic strokes. Ischemic is just not enough blood flow to the brain. It's not a bleeding stroke. Thrombotic occurs from injury, so that is the bleeding stroke. A lot of times TIA is the precursor, so they will have a transient ischemic attack. It only lasts a few minutes, but they a lot of times have them documented. Embolic is when the emboli lodges in the wrong place in the cerebral artery, and that's embolic. Lacunar, this is considered ischemic, but it's a small penetrating artery with complete occlusion. And then thrombotic is more common from diabetes or hypertension. It results from thrombosis or narrowing of the blood vessels. The difference from a stroke and a TIA is a clinical manifestation. They're pretty much the same, but it lasts longer. In TIA, ischemia occurs without a cell death or infarction. It's kind of a warning sign. Hemorrhagic stroke, this is from the bleeding. This is the actual bleed. And death occurs within hours. Although I have, in my experience, seen us do some wonderful things with hemorrhagic strokes. It's caught early. The key is catching these strokes early. When it's bleeding and they see it on CAT scan, we can't do any of that, the thrombolytics, but there's ways to coil it. So they would go to interventional radiology, IR, and have them coiled or clipped off. So it's bleeding in the brain, and 50% of deaths occur within the first 48 hours. So the key is finding it fast. It's usually sudden. The one that I had, a patient, she came in complaining of the worst headache of her life, and that was something the doctors always said, okay, anytime they say that, let's get them to CAT scan right away. Got them to CAT scan, and I was with the patient, they're monitored, and as soon as we saw the CAT scan, we're like, okay, let's go, because you could see the blood on the CAT scan, and we called ahead, told them to arrange the cardiac room, get respiratory down there to intubate, and we basically ran back with the stretcher. And so she was intubated. She ended up having a really good outcome because they clipped the bleed. But the pictures that they got from CAT scan was able to help the doctors see where it was. And this was a young woman, probably in her mid-30s. Typically, hypertension is the most common cause for a hemorrhagic stroke, but not always. There can be other things too. You always want to know what medications they're on, what coagulation disorders they have, their medical history. And sometimes it could be from trauma from before. Aneurysm is located, it's a blood-filled balloon-like bulge in the wall of the vessel, and it could burst at just the right time. So clinical manifestations, they don't change between ischemic and hemorrhagic. They're pretty much the same. There's a change in the level of consciousness, maybe some slurring of speech, motor deficits on one side or the other, and it's usually contralateral, so opposite side of what's going on. So you want to assess the speech. You want to look at their face, have them smile. You want to look at their arms and see if either arm is drifting. So looking at those things, speech, of course, and what time did this happen? The key is it's got to be witnessed. So if somebody wakes up with these signs, we don't know when it happened. The biggest thing you can do for stroke is prevent it. Keep a normal blood pressure. Stay active, stay healthy. Those are the big things. Control any heart problems. This is the most important. But when you go in to assess the patient with a stroke, your initial assessment, start at the top, work your way down. You want to look at eyes. You want to look at breathing. You want to look at ears, mouth, smile. Have them smile if they're awake. Ask about headache. Ask about hearing problems. Ask about numbness or tingling. We want to take their vital signs. The heart rate might be increased or decreased. Blood pressure may be elevated or it may be normotensive. So really get everything right, head to toe, all the way down. See if they're urinating. Have they had any issues? Nausea, vomiting. And then usually we would put an IV in, but we may or may not put fluids in. Typically not. We don't want the fluids in because that can always increase the intracranial pressure. And then two, you want to find out, are they diabetic? Test their blood sugar. Maybe they don't go to the doctor. So you want to see, how is that doing? Here's some diagnostic tests. Again, looking at CAT scan, MRI, making sure that they have their band on, that they're consented, that there's no other priorities before you send them over to those places. Get the labs drawn, check their glucose and all that. TPA, that may be given if it's an ischemic stroke. So TPA, tissue plasminogen activator, and that will thin out the blood for clots. You have to do a risk score, so you're going to look at them and see if they've had any recent surgeries, any recent trauma, things like that. You will have a list of all the things that would be contraindications. You may have to give antihypertensive medications as needed, antipyretics, anti-seizure, and things like that. On this particular slide, you should be able to find a link to a craniotomy if you're so inclined, and it's a YouTube. Last but not, no, it's not last but not least. You want to remember this: face, arms, speech, and time. This is an acronym for stroke. FAST, fast. You want to get them there fast. This one, you can look at this YouTube on transient ischemic attack. Sports and head injuries. This is a really good article on sports head injuries, and I recommend that highly. And then last but not least, you want to know about intracranial pressure and how to prevent its elevation. You want to look at the etiology, pathophysiology of strokes, look at the clinical manifestations, what type of tests would be done, and teaching to prevent. That's it. Thank you.